Hey everyone, welcome to the Happy Flosser podcast. My name is Billy Luntz. I am your host, and I'm here to talk to you about all things dental hygiene to support you on your journey through the dental hygiene program. It is really great to be with you today. And guys, guess what we're talking about today? We are talking about ultrasonics. There's so much to know about ultrasonics, and I think sometimes students start off really scared of ultrasonics. And it's one of those things when it comes to power scaling, the sooner you just jump off the cliff and really learn about the handpiece and learn about the technology and understand how it works, you just gain a lot more confidence. And at first, honestly, when you're using ultrasonics, there's just so many things going on. You've got water control, you've got the foot pedal, you're trying to manage the water, you're trying to be able to see, and then you've got this power scaler moving and grooving, and you have to hold it a certain way, and you have to keep the tip moving all the time because that signal is causing that tip to move, and all these things are going on. So your brain is kind of on overload at first. And compared to hand instrument technology, when you first hold an ultrasonic in your hand, it's very, very heavy. So we give you this insert, we teach you how to properly and adequately connect everything together, and then we give it to you and you put it in your hand and it's like, oh my goodness, this is so much heavier. Once you put the insert in, everything gets a little cumbersome to you. There's hoses, and they have these wonderful things that you can slap on your wrist now and connect the hoses. So that takes away some of that weight that students typically notice right away. So let's just talk about the different parts of the system. So when you're looking at an ultrasonic insert, you have a stack. So that's one of the parts. Now the stack is actually the energy source for the insert. The stack should be straight. And when you look at the stacks, you'll see it's just a bunch of stacks, metal. It's almost like little metal plates. You don't want any bending there. A bending of the stacks could actually interfere with how that insert actually works. So the insert, especially the stack, should be treated as a fine surgical instrument, very, very carefully and cautiously, because two things that I see happen. Students will actually bend the stacks or they'll actually bend the tip if they drop it on the floor. When the insert is working correctly, it fits easily and freely into the handpiece. That's how you know that the stacks are nice and straight. Now, if you think about this, the stacks they move by elongating and contracting on a horizontal plane, like stretching an elastic band. So if those stacks are bent, the elongation and contraction could be restricted. And then the other thing you want to do, the stack tells you a lot of information. If you look at the side of the stack, it'll have the date and the tip style. It will say either SLI for slim or FSI or TFI, and then the frequency will also be stamped on the stacks. So the date code denotes the year first and then the month of the manufacturer, and it will say 30K or 25K on the stack. So that really tells you a lot of information that you need to know when you're first getting to know all of the different inserts. So the connecting body, it connects the stacks to the actual insert tip. And then you'll see that there's a rubber O-ring. The rubber O-ring is next, and I'm working my way up to the tip. The rubber O-ring actually stops the flow of water from coming outside of the handpiece, and it directs the water to go down through the tip. So when you're bleeding the handpiece to get rid of air and the water flows out of the handpiece, you're going to wet that O-ring and lubricate it so that that O-ring can go right into the insert and it doesn't wear out as well, because it will dry out and crack over time. And then you have the actual insert tip. So the tip is the working end of the insert. So with magnetotechnology, you can work with all surfaces of the insert, but we take caution never to use the point of any type of ultrasonic insert tip perpendicular to the tooth because it may cause a gouging of the tooth surface. So if you're looking to see like what type of insert do I need, there's lots of things that you can look at depending on what company that you're using. Sometimes they're color coded. Sometimes there's a label on the grip, and sometimes there's a stack strength indicator. So the longer stacks that are greater than 3.5 inches, those are your 25K. And the shorter stacks are 3K. these two inserts are not interchangeable using the same system. So it's really important that when you're buying or purchasing these, you want to make sure that you pay close attention to the stack strength and the length that you're getting. So when you're thinking about insert selection with ultrasonics, you want to make sure that you're aligning the insert that you're using with the job. So what type of patient do you have coming in? So slim line SLI inserts, they're about 40% thinner than a standard insert, and they're available with an external water loop. They're available with an internal water delivery. They're designed for light to moderate debris or fine root debridement. So the SLI S straight is typically what most clinicians would call the universal, which is a little bit misleading because that straight insert is designed for pockets that are 4 millimeters or less, but it can be used on every surface. So adaptation is not suitable for anything more than 4 millimeters because of that straight design. It doesn't really fit against that curved tooth surface of concavities or periodontally involved root areas. So this is why you would use your curved tips. So the contra angle of the curved tip insert actually allows for better access and adaptation to those deeper pocket infiltration areas. So keep that in mind when you're thinking about the slim lines and you're thinking about the straight and the right and left, what you're actually asking it to do when you're thinking about how it adapts to the tooth structure. So that straight is for 4 millimeters or less of a pocket depth and for deplaquing therapy during periodontal maintenance appointments. And its tendency is to direct the point toward the root. And thinking about that, that is considered the vertical technique, right? So the right and left designs were developed to treat those areas of the roots that are not accessible for instrumentation due to periodontal destruction. So those curved tips will adapt to the indentations of the cavities on the root surfaces without damaging the hard and soft tissue. So using the convex back portion of the insert against the tooth is a very effective way, making sure that that terminal shank or the working end is parallel to the long axis of the tooth. This is a great way to really gain access to those areas without damaging soft tissue, because the specific angle of the insert keeps that instrument adapted to the tooth. Remember, all those things that you learned in oral anatomy, all those root concavities, the more you keep those in the forefront of your mind when you're doing instrumentation, the better instrumentation you will have chairside with your patient. Let's talk about the power as it pertains to like the dial setting on your unit or the electronic view box and the length of the strokes. When the power is set to medium or to high, you will have a wider stroke. This is exactly what you want when you have heavy debridal removal. When you have a lot of debris, when you have heavy calculus, Calc 3, Calc 4 patient, for removal of that heavy calculus, you want to use a wider or larger diameter insert, such as a 10, 100, or 1,000, and a more powerful stroke. The fatter that tip is, so opposite of slimline, fatter that tip is, the more power you will have and a wider stroke you have. And when you're doing fine root work, you want a smaller, shorter stroke to achieve periodontal debridement. So think about that. You would have your setting on a low power setting for that application. Now, not all inserts are used at the same power setting. So the basic rule of thumb is the thinner the tip, the lower the power setting. And that's really important for you to keep in mind when you are working with these systems. So if you have if you have a thin cert, you would not want to put a thin cert on high. All right. That's really important for you to make sure that the tip that you're using, that you're following the manufacturer's instructions, and that you're doing it correctly, because you don't want to cause any damage or problems. So when you are first allowing the flow of water to come into your handpiece and then you put your insert in, think about what happens when you then press the pedal and now you have activated that tip. So with magnetostrictive technology, a low voltage signal causes that tip to move. The handpiece contains coils that activate the inserts, causing them to vibrate. Now, the inserts are easily interchangeable with magneto technology. The water flows over and through the stacks, preheating the water to be a comfortable temperature, and then flows to the insert tip. The water at the tip is used to lavage away debris. Think about what you're doing. You're actually flushing out some of the free-floating pathogens that are in the tissue, right? You're removing endotoxins and you're cooling the tooth to tip interface that is present when you're using ultrasonic scalers. So the cable sometimes gives students trouble. So some people wrap that cable around their forearm, or they hook it inside the pinky finger or the hand that you instrument with to prevent wrist fatigue. But we have some really great products on the market that are helping with that as well. So think about that cable. It's a soft silicone-based material that easily drapes, but you don't want to run over that with your chair because you could actually break that. And those are super expensive and will limit your ability to use your ultrasonic. Let's just briefly talk about insert care and maintenance. So you don't want to put your inserts into cold sterilization or spray them with disinfectants. That'll reduce their efficiency and shorten their life. And we know how expensive they are. You want to really just clean them the same as you clean your hand instruments. Limit the hand contact with contaminated instruments. So using a cassette for ultrasonic cleaning is definitely safer because you're not going to poke yourself or inadvertently stab yourself with a used insert. All the inserts that you use should be sterilized. The insert should be bagged or placed in a cassette during sterilization. And when you're using a bag, be certain that they're paper or a combination of paper and plastic. And all pouches build up too much heat and may damage the insert. So a plastic-only pouch is not recommended. When you're using paper and plastic combination pouches, place the bag in the autoclave with the paper side. This is the greatest controversy. Up if the manufacturer says up, and down if the manufacturer says down. I can't tell you how many discussions I've had with clinicians who swear by autoclave paper side up and autoclave paper side down. But what's interesting is we have two different types of autoclaves at my facility, and one manufacturer says up, one says down. So you have to do what the manufacturer's instructions are. It's about allowing the heat to escape. So there's lots of people who have very strong beliefs about that. So go with what your faculty or your manufacturer instructions are for where you go. Now, the frequency, there's a couple of terminology that I'd like to just share with you when it comes to ultrasonic tips. So frequency is the number of times per second that the insert tip moves back and forth during one cycle. So a cycle is considered one complete elliptical stroke path. Well, kilohertz equals to 1,000 hertz or 1,000 cycles per second. It is a little hard to kind of wrap your brain around how fast, what the frequency is for that tip, how fast that tip is moving. So optimum frequency ranges between 18 kilohertz and 32 kilohertz, and 32 is above the audible frequency, so it's within a range to allow greater patient comfort and maximum life of the insert. So we want that middle range zone. Now, the active tip area is affected by the frequency. So in the 25 to 30 kilohertz range, the active tip area is approximately 4.3 millimeters. In the 40 to 50 kilohertz range, the active tip area is generally less than 2.4 millimeters. So you can see how if you're in the right range, right, above the audible frequency, you are actually having a better active tip area. All right. So let's just talk about a couple other pieces. Power. The electrical energy in the handpiece used to generate the movement of the insert. So increase the power increases the distance that the insert moves without changing the frequency. So the stroke. So when you turn up the power, you're increasing the size of the stroke. So the stroke is the maximum distance between the insert moving in one cycle. So that power knob adjusts the stroke. What I want you to think about, because you can't really see the stroke moving, think about a brick wall and a hammer hitting that brick wall. Every time you turn up the power, you're hitting that brick wall harder because you're increasing the distance in the stroke. Now, amplitude is 1/2 of the stroke size, and load is the resistance on the insert when it's placed against a deposit on the tooth surface. So it's important for you to think about these things. What happens when I put the tip, the powerful tip, when I put a load on a calculus deposit? What actually happens? So clinical power is the ability to remove the deposits under a load. The stroke frequency and the type of motion, whether it's elliptical or linear, and the angulation of the motion against the tooth surface are factors that determine the clinical power. Here's a little secret. Most early clinicians find that ultrasonics are underwhelming. They're like, I thought this was going to work way better than it does. And you know why they have a hard time? Because of their angulation or their adaptation. They don't have the tip in the right place for maximum clinical power. So that will all change as you become a skilled clinician and things get a little bit easier. So a couple of other things that you have to keep in mind that are attributed to ultrasonics are things like acoustics. So there is energy that's associated with sound waves that come off of ultrasonics. And there's lots of people that are doing research on the need for ear protection. Because we also have acoustic streaming, which is unidirectional fluid that's caused by ultrasonic waves. And acoustic streaming occurs at lower acoustic pressure than cavitron. So when we have acoustic streaming, it's constant moving. These are sound waves, energy, sound waves. You definitely can't see, but can have an impact. And then we have acoustic turbulence. Tip stroke causes coolant to accelerate, producing an intensified swirling effect, which disrupts the bacterial matrix or the biofilm. This effect is increased as the power knob is adjusted to a higher power setting. So think about what that sound wave does to the biofilm in the gingival sulcus. This is really significant. The more that we've learned about biofilm, the more we understand the impact that ultrasonics have on the biofilm in the subgingival areas and in the furcations and in the root concavities and in all the places that we want it to go. And then the other ultrasonic effect I'll just say is cavitation. So the formation of bubbles in liquids by rapid changes, such as those induced by ultrasound. When bubbles implode, they produce shock waves in the liquid. Think about what that does to the biofilm. So when you think about the effects of ultrasonics on what you're doing chairside with your patient, there's a lot of things for you to factor in and consider. Take the time to practice and learn, and then connect the dots between your tips and oral anatomy root morphology. Use your insert and actually look at how it adapts on a tooth on your typodont so you can connect the dots in what does that adaptation look like and how does that impact how I'm working chairside with my patient. Knowing that what happens when you turn up the power setting on the ultrasonic, what actually happens? What does cavitation do and acoustic turbulence in the gingival crevicular sulcus? How does the gingival crevicular fluid respond? And what's actually going on in the sulcus when you are in there with an ultrasonic tip? All of these things will go a long way at helping you connect the dots between what you're doing and the science behind what you're doing. I hope you guys have a great week. We'll talk to you soon. Be sure to subscribe to this podcast so that whenever a new episode launches, you will get a notification so that you can take little steps towards learning all that you need to know for dental hygiene school. Take care, everyone.